Good morning. It's a pleasure to be here. I'm always excited to talk about vasculitis, but if it's in a sunny location and gives me a break from the polar vortex and the torrential snow, this is wonderful. So we'll be talking about large vessel vasculitis this morning and trying to also review some concepts that are common to all forms of vasculitis. So as you know, vasculitis involves inflammation of blood vessels, but sometimes inflammation of blood vessels can be somewhat of a vague term. So what is inflammation? And if any of you have had some minor trauma, a cut or splinter or damage, injury to a finger, you're all familiar with the signs of inflammation, and those are redness, pain, swelling, and when we think about blood vessels, though, that can be a little more difficult to understand. So in the setting of a blood vessel being inflamed, we're again seeing here just a cartoon showing that if you injure the skin, and maybe in Arizona I should have had a cactus spike here, but what happens is that then white blood cells, which are part of our immune system, are going to come to that location and produce inflammation. So again, inflammation is going to cause swelling, redness, warmth, pain, and these white blood cells are there to try to repair the damage and the injury that's been done. So they are there to clean up any foreign material, like bacteria, for example, that may have entered the wound. But they also are then going to start the repair process, and the repair process will involve scarring and eventually healing over of the skin. But when you think about inflammation in a blood vessel, it's hard to understand where is the swelling, the redness, the warmth, the pain. Well, it's different, right? Because a blood vessel is a tube. And so a normal blood vessel looks like this. There's a canal on the inside, which we call the lumen, and then there's a wall to the blood vessel. But because the blood vessel is in the form of a tube, a channel, if there is swelling and inflammation, then that wall is going to become thickened. So inflammation of blood vessels leads to thickening of the wall, but when you have thickening, now look what's happened to the lumen. That's the channel where blood is flowing through. So that has now become narrow. And narrow means that less blood can get through that channel, and lack of blood flow, of course, is going to be damaging to whichever organ that blood vessel is supplying. So in the case of large vessel vasculitis, for example, one of the most feared consequences in giant cell arteritis is loss of vision. And that's because we're interrupting the blood supply to a very important organ, which is the optic nerve at the back of the eye. So when we think about vasculitis, and you'll be hearing more about small vessel vasculitis later in the morning, but when we think about vasculitis, we try to think about which blood vessels are affected in the patient that we are evaluating. And so we go from thinking about the largest blood vessels in the body, and that's the aorta, that's the main channel that's coming out of the heart. And then the aorta divides into various branches, like the branches of a tree. And there are branches going to the head and neck, branches to the arm, and then later to the organs in the chest, eventually down to the legs. So these are called large blood vessels because they are the largest blood vessels in the body. At the very other end of the spectrum, here we're seeing a kidney that's been magnified, and so now the branches are smaller, so we call them medium-sized. But eventually, if we were to take a little snippet, a little biopsy of a kidney here, and blow it up under the microscope, we're now going to be able to see very tiny blood vessels or capillaries that are inside the kidney. And so we're going from the very smallest, capillaries and other small blood vessels, to the very largest. In my presentation, we'll be focusing on forms of vasculitis that affect the large arteries. And the most common one of those is giant cell arteritis. There is another condition, Takayasu Arteritis, which is less common, and we'll touch on that as well. So when we think about giant cell arteritis and Takayasu Arteritis, as I mentioned, we're referring to a form of large vessel vasculitis because they both affect the largest blood vessel in the body, which is the aorta, shown here, and that's the artery that's coming right out of the heart and then gives off branches that go to the head and neck. and branches that go to the arms. And this area here, these blood vessels, are the ones that are most commonly affected in GCA and Takayasu. So you can see, or start to understand, these blood vessels are supplying the head, where of course there are very important structures, right, like the brain, the eyes, and also the arms. And so when we have blood vessel inflammation here, we said inflammation will lead to thickening, which leads to narrowing and can lead to interruption of blood flow. So this interruption of blood flow is going to affect then the organs that we just talked about that are mainly in the head and in the arms and sometimes other areas in the body. Oops. So one of the biggest questions that we are asked when we diagnose somebody with large vessel vasculitis or any form of vasculitis for that matter is, why did I get this? And there's a lot, unfortunately, that we still don't understand, but there are some things that we do understand. And we know that there is a genetic component to these diseases. It's more complex than a simple inheritance from, for example, a mother to a child. It's a much more complex situation because in vasculitis and in most autoimmune diseases, it's not one gene, but it's a set of genes, and these genes have to come together in the right sequence or the right pattern in the right individual to then be a risk factor for the disease. But we do know that autoimmune diseases, vasculitis included, do have a genetic component. And in giant cell arteritis, part of that genetic component relates to where people are from. So we know that in Northern Europe, in Scandinavian countries, in other countries like England and other parts of Northern Europe, the risk of giant cell arteritis or the frequency of giant cell arteritis is about twice that in Southern Europe. And that seems to relate to a genetic component. Again, we know some about the genes that are involved, and it's not one gene, but again, multiple genes. And then, of course, in the US, if folks are of Northern European heritage, they have a similar increased risk of the disease related to that genetic background. But it's not all about genes, right? There may be something in the environment. And so over many, many decades, folks have asked whether a virus, a bacteria, or other infections might be the cause of, say, giant cell arteritis or other forms of vasculitis. In the setting of GCA, several viruses, several bacteria have been studied, and yet, to this date, none have been conclusively shown to be the cause of the disease. Now, it's possible that infections may trigger the disease or may result in a higher risk of people getting the condition. So, for example, in giant cell arteritis, there's been a lot of interest as to whether herpes zoster, or shingles, which you know is caused by the chickenpox virus, causes a painful blistering rash. There's been a lot of interest that maybe this is the cause of giant cell arteritis. It's been debated. There are different studies showing this, that this may or may not have a correlation. There was a nice study showing that it probably is one of the risk factors, but certainly is not the cause in everybody. But those who have shingles may be at higher risk of then developing giant cell arteritis. Again, perhaps this serves as a trigger to the immune system, and then the immune system goes wrong and starts to attack blood vessels. There's another interesting concept out there and a lot of interest in the role of smoking in triggering giant cell arteritis. Most studies showing that it is a risk factor. Either current smoking or a history of previous smoking may trigger the development of GCA. So again, there's more for us to learn. There is something about aging, because giant cell arteritis affects individuals over the age of 50, and the average age when this disease strikes is usually in the early to mid-70s. It is the most common form of vasculitis in adults and affects about 1 in 5,000 people each year. So it's estimated that there's close to about 300,000 people in the US with this condition. You can see here the swelling along the temporal arteries at the side of the head. That is a classic finding or symptom of this disease. So how does giant cell arteritis come about? How do we know that people have this disease? What kind of symptoms does it produce? So we talked earlier that the blood vessels to the head are affected. So headache, soreness at the side of the head, swelling of those arteries on the side of the head would be a common classic symptom. Because the blood vessels to the muscles, the chewing muscles, are affected, then a lot of individuals will develop pain in their jaw when they're chewing food. And it again relates to lack of blood supply to those big muscles that move our jaw that are not receiving enough oxygen, enough blood supply because of the damage and the narrowing that's caused by this vasculitis. But GCA comes in a lot of shapes and sizes. Again, one of the more feared consequences is that individuals may suddenly, unexpectedly have painless loss of vision in one eye, and if not treated, could be also involving both eyes. But again, because of the disease affecting the blood vessels in the head, we're concerned about and evaluate carefully because there may be risk of stroke. With giant cell arteritis comes a condition called polymyalgia rheumatica, which we'll talk a little bit more about in the next slide, but this is an inflammatory condition where there's pain, stiffness, and inflammation in the shoulders and hips most often. GCA may come in with simply people not feeling well. So sometimes folks are in the hospital because they have fever, don't feel well, or losing weight, have a poor appetite, and we're looking for infection, or sometimes we're looking for cancer, and then unexpectedly we stumble on a diagnosis of giant cell arteritis. Some individuals, again, we said the blood vessels to the arms are affected, and so that would produce arm pain with activity like vacuuming or showering, and then the pain gets better when the arms are at rest. So again, it speaks to this problem with getting blood supply, getting blood flow to the arms. Some individuals even come in when there already is damage from the disease, and one of the damage aspects that we look for carefully is damage to the aorta, where an aneurysm can form, and sometimes that can be the first first indication that the individual has a form of large vessel vasculitis. Again, there's a lot of overlap between these two conditions, giant cell arteritis and polymyalgia rheumatica. And PMR causes stiffness and pain in the neck, the shoulders, the hips. Oftentimes, folks have a hard time getting dressed because of pain in the shoulders, difficulty getting up from a seated position due to the pain and inflammation in the hips and in the thighs. The two go closely together, and when we see individuals with polymyalgia rheumatica, we want to very carefully look at whether there is an associated vasculitis, giant cell arteritis in particular, because sometimes the symptoms can be difficult to tease out as to whether somebody has only one condition, so only polymyalgia, or only giant cell arteritis, again, mainly because oftentimes there's overlap between the two, and the two go together very frequently. Very briefly, Takayasu arteritis has a lot of similarities with giant cell arteritis, but is much less common. So this condition is more frequent in populations in Asia, but is also seen in the US and worldwide, much less common, affecting about 1 to 2 million individuals per year. This affects younger individuals, so that's one of the big differentiating features that we can tell them apart, that oftentimes these are young women below the age of 40, and an average age is about 31 or so. And again, the cause remains, unfortunately, largely unknown. There are some genetic associations, again, mainly seeing this more frequently in Asian populations, but again, seen worldwide. How does Takayasu arteritis come in? With symptoms that are very similar, again, keeping in mind this condition is affecting predominantly the blood vessels to the head and to the arms. So again, we see symptoms that may be neurologic in nature and sometimes difficult to tease out. Headache, weakness, dizziness, and other neurologic symptoms. But also, just like we mentioned with GCA, muscle and joint pain is common. folks may have some symptoms that are difficult to recognize. Fatigue, malaise, fever, just not feeling well, basically. Again, arm pain with activity, so you see very common symptoms that are related to giant cell arteritis. And again, we have difficulty because we don't have a good blood test to be able to diagnose these diseases. So whether we're referring to giant cell arteritis or to Takayasu, we are still in the process going on for decades to find a diagnostic blood test that would easily tell us, yes, we can rule this disease in or we can rule it out. We do have, as you're all very well aware, is we check markers of inflammation, the SED rate or sedimentation rate, and the CRP, both of which will become elevated when there is inflammation in the body. The difficulty with these tests is that they tell us something is not right, but they don't tell us what the problem is. And so other conditions, whether it's an infection, any illness in particular, can cause elevation of these markers, and then we have to tease out, is this due to vasculitis or is it due to something else? But we are still waiting to have a test where we conclusively say, yes, this is GCA, or no, this is not GCA. In small vessel vasculitis, ANCA testing is extremely helpful. We're not there yet with large vessel vasculitis, unfortunately. There are some newer ways of picking up vasculitis, and as some of you may be aware, biopsy, obtaining a small segment of the artery in giant cell arteritis, is really one of the main tests, or the gold standard test that we use. But we also have availability of ultrasound, which can show us whether there's inflammation or thickening in the blood vessels in the head. So this is an ultrasound of a normal temporal artery. And what you're seeing here is, if I can just pause this for a second, is a blood vessel. And this is the temporal artery right here. And the red blob in the middle is blood flowing through. So this is a normal blood vessel where there's a nice, wide, open channel of blood getting through the artery. But what happens in the context of vasculitis? So we'll just keep the normal one up here for comparison's sake, and here's the artery that's affected by vasculitis. So here's the difference, right? So here you can see that the channel is now smaller. The colors are mixed, which means that there's some turbulence in the blood flow, and the wall of the blood vessel is thick and swollen. So this is the ultrasound image showing us that there's something wrong in this blood vessel. It's inflamed because it's thickened, it's swollen, and the amount of blood that's flowing through is less than there should be. So when we in clinic, or when we're seeing somebody where we suspect they may have large vessel vasculitis, like giant cell arteritis, we may do a biopsy taking a small sample of the artery, but we do have newer techniques that we're able to use that are non-invasive. And some of those include the ultrasound that I showed you earlier. This is where we would do a biopsy site on the side of the head here. But again, imaging now, so we're using radiology techniques, being able to get pictures of these blood vessels to look for inflammation, is very helpful in terms of complementing, say, a biopsy, but also sometimes is the way that we can establish a diagnosis, because biopsy may not be feasible, the biopsy may not be positive. Sometimes the inflammation is not all the way up in the head, but is predominantly in the chest area. And so using these newer and sensitive imaging techniques with scanning, we can pick up vasculitis and make a diagnosis that way. And I'll show you some examples. So how do we get images or pictures of the blood vessels? We saw some ultrasound images, but CT scan is also commonly used. As you know, CT scan uses this kind of donut-shaped machine, and it's basically taking slices of the inside where we can see the internal organs, but we can also see blood vessels, and can be a very helpful test to try to pick up, is there narrowing, is there inflammation in the arteries? We also use MRI scanning, which is a little different in that this is a longer tube, narrow tube. Each one has some advantages. CT scan is faster. MRI takes longer. MRI is noisier, as some of you may know. And some individuals, you may not tolerate being in a very enclosed environment as in an MRI scanner. The MRI, both CT scan and MRI show us beautiful pictures of the blood vessels. And again, we can see, is there any widening? Is there any narrowing in the arteries? But they can also show us, especially with an MRI scan, is there swelling in the artery? And is there a contrast? So oftentimes they will inject a dye with these scans. And if that dye goes to the wall of the blood vessel, it can tell us whether that blood vessel is inflamed or not. And I'll show you some examples of that. So what we're looking for in large vessel vasculitis, whether it's GCA or Takayasu, is we're trying to see, is there narrowing in the blood vessel? So this is an example of an angiogram where a catheter is introduced in the artery. There's dye that's injected in the blood vessel, and we're seeing that the blood vessel is more normal here, but then here there's an area that's tapered, that's narrowed, and of course is limiting blood flow. The same blood vessel is seen here with an MRI scan. MRA stands for MR angiogram, meaning we're using the MRI to show us the blood vessel, and you're seeing very similar findings here. So a normal blood vessel on this side and a narrow blood vessel on this side, very similar to what was obtained by the angiogram. And again, there's narrowing here and narrowing here. So these tests are very helpful at showing us, is there narrowing in the blood vessel? But we also want to know, could this be just a cholesterol plaque, which we see in folks who have high cholesterol, perhaps diabetes, high blood pressure, smoking, and so forth. But we're looking to see, is this a cholesterol blockage, or is this a vasculitis type of narrowing or blockage? And so CT scan and MRI are very helpful, because then if we take a slice across this blood vessel, we can look at the wall of the blood vessel. So this is an example of the aorta, again, the largest blood vessel in the body. And this is the aorta here when it's starting to leave the heart, and this is the aorta here in the back of the chest. You can see that the aorta here, you actually cannot see the wall of the aorta because it's so thin that it almost is not visible on scans. But look at the difference of the wall of the aorta here. There's a tremendous amount of swelling and thickening, which is the vasculitis. So that's what we're looking at in this patient. So we know that this is not a piece of cholesterol blocking or thickening the blood vessel, but it is this swelling that's going all around the blood vessel, causing inflammation and damage to the artery. Similarly, again, this is normal, this is abnormal, so it's this thickening and swelling that we're looking at. This would be an example of an MRI scan showing that there's enhancement, meaning it's bright, it looks white, and that relates to inflammation and thickening, and that inflammation gives us an idea that there still is ongoing inflammation from the vasculitis, and we need to treat that and bring that inflammation down. We also use PET-CT. PET scan is a form of scan where the radiologist, the X-ray specialist, can inject a sugar dye, it's glucose, that has a small radioactive tag with it. And if the blood vessels are inflamed, then the blood vessels will light up. So here's the aorta, as I showed you earlier, and the bright color shouldn't be there. It should be looking like this kind of bluish purplish background, but if there's bright color here, this is the brain, which is normal. The brain is using up a lot of sugar, and the blood vessels will take up the sugar if they are inflamed. So the PET scan can be helpful in telling us, one, does the individual have inflammation in their arteries? And sometimes we also use the PET scan to figure out, is the inflammation active or not? Because as you know, in vasculitis, we go through phases where the disease is active, and then we can bring the inflammation down or into remission with treatment, but at times the inflammation can come back, and that's a relapse or a flare of the disease. So this technique, which unfortunately is expensive, and so we use it judiciously, but sometimes it's very helpful in trying to understand where is that inflammation coming from. So somebody who comes to us with very high inflammation markers, where we're not sure, is this a form of vasculitis? What is generating that inflammation? Like I said, the numbers tell us something's wrong, doesn't tell us what it is. And there are situations where then this form of scan is very helpful in telling us this is where the inflammation is coming from. Sometimes we find things that are unexpected, maybe a focus of infection, or maybe a form of cancer that was not previously picked up and can be seen on the PET scan and gives us a clue as to where to then look to figure out where is that inflammation coming from. So we'll talk a little bit now about treatment of large vessel vasculitis. And again, this is an interesting piece of history I wanted to share. So we have made a lot of progress over the years. So as you may know, the first patient to have a biopsy for GCA was at the Mayo Clinic in the early 1930s. And they were trying to figure out what is this disease and what causes it. And at first they thought it was an infection. They were even injecting arteries into individuals to see whether they could transmit the infection, and were not able to do that. But in this poor woman, they thought maybe this is dental sepsis. So this is 1931. So they said the patient looks better. They thought it was from her teeth. They pulled 8 teeth for this individual and said, you know, the rest of her teeth should be taken out when she goes home. And they gave her potassium iodide, which in those days was used for infections. So this is 1931, and we've, again, have come a long way. And of course, soon after that, in the 1940s, following the discovery of cortisone, they started to treat patients with cortisone and realized that one of the important consequences of using cortisone was preventing blindness, right, in giant cell arteritis. But in general, when we think about vasculitis, we think about what's the first step. So the first step is we got to put out the fire. We have to put out the inflammation that's going on in this disease. And so when somebody's newly diagnosed, of course, their disease is active, right? The blood vessels are inflamed, and we want to put out the fire, so we say we want to induce remission. So we want to put out the fire, quiet the disease down, but then we want to keep the disease in remission, because some of our diseases, there's always some embers sitting there in the blood vessels, which can then cause a flare-up and recurrence of the disease. So after we turn off the inflammation, we want to keep the inflammation turned off. And sometimes, of course, as we said, the disease will relapse or flare up, and then we kind of have to start over again. So these are the general phases of how we treat vasculitis. In giant cell arteritis and large vessel vasculitis, for about 70 years or so, it's really been prednisone, 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 and more prednisone, which, of course, has its downsides, and we'll talk more about that. There are some common principles that we try to encourage folks when we're dealing with treatment of vasculitis. And of course, just like everybody around us, we should follow a healthy diet and exercise. But the reason we emphasize this in people with vasculitis is because we're trying to counteract oftentimes the side effects of prednisone and glucocorticoids, right? Because they're going to contribute to weight gain, they may contribute to bone loss, muscle deterioration, and so staying active is important. As you know, any treatment for vasculitis, or most treatments, are associated with a higher risk for infection, and therefore avoiding those who we know are sick, avoiding places that may be a high-risk situation, like, say, a nursing home, being aware of infection, utilizing vaccines that are available for the prevention of things like influenza, pneumonia, and now even the newer shingles vaccine, the Shingrix vaccine, can be used in individuals on immune suppressants. We avoid any live vaccines like the old shingles vaccine. The Zostavax would be not allowed in somebody on high-dose steroids. And we try to prevent this rare form of pneumonia. I'm sure Dr. Specs and others will talk more about this. There is a rare form of pneumonia called pneumocystis, which can happen in individuals on high doses of prednisone and other immunosuppressants. We worry about the bones and want to prevent bone loss, and so we are very cautious with preventing or treating osteoporosis to prevent fractures. So glucocorticoids for giant cell arteritis, again, have been around for more than 7 decades. They have a lot of good side to them. We know that people feel better on prednisone. We know that inflammation does improve with these medicines. So I'm sure you've seen very rewarding results that after starting treatment, symptoms are better and the markers look better, SED rate drops, CRP drops. And in giant cell arteritis, there's a very critical component to this, which is the prevention of vision loss. And this is because the blood vessels that supply this optic nerve, the optic nerve at the back of the eye, of course, is critical for us being able to see. And if the blood supply to this optic nerve is interrupted due to vasculitis, then there can be loss of vision. And without treatment, that is one consequence that we want to avoid, and so starting treatment early is very important. But not everything is good about steroids, right? We know that damage to blood vessels can still happen. Flares, like this individual who's having these polymyalgia symptoms, this aching and stiffness, it's very common for it to come back, and you're all aware of side effects. I believe we have a full discussion later about the many side effects of prednisone. But the challenge, and one of the questions we get asked a lot, is how long will I be on treatment with this giant cell arteritis? And in book chapters and in maybe patient brochures, we often write that the treatment is going to go on for 1 to 2 years. In actual fact, it's actually oftentimes even longer than that. So we and others have seen that less than half of patients with this disease are totally off prednisone even after 2 years from the diagnosis. So it's a very prolonged treatment course. Now again, most people are able to come down on the prednisone dose from a high dose to a low dose, but it's very common for people to be continuing long-term on a low dose of this medication, either due to recurrent polymyalgia symptoms, this aching and stiffness in the joints, or sometimes even due to unmasking of symptoms related to osteoarthritis. We all develop some wear and tear in the joints as we grow older, and prednisone will often help that or mask that, and then as the prednisone is being withdrawn, those symptoms may come back. A few words about tocilizumab. This is under the brand name of Actemra, and for giant cell arteritis, this is really the first biologic approved, studied and approved just a couple of years ago. It blocks a messenger in the immune system called interleukin-6. This interleukin-6 helps cells of the immune system talk to each other, and tocilizumab blocks this IL-6. So this IL-6 messenger is trying to get to the immune cells, and Actemra will block that IL-6 from getting to where it needs to be. So the bottom line is it will reduce and help suppress inflammation. It's given either as a subcutaneous injection once a week or as an intravenous injection, generally about once a month. It is effective because it can reduce the number of flares or relapses in people with giant cell arteritis, and it allows us to use less prednisone. So in other words, a faster taper, and patients may, instead of being on prednisone for 2-3 years or longer, may be able to come off prednisone within perhaps 6 to 9 months or sometimes shorter. So it has advantages, but of course, like any other medicine, there are risks, particularly as we block the immune system. There are risks for infection. There may be risk for an allergic reaction to the medicine. We monitor blood counts very carefully with this drug. There may be an increase in cholesterol, in blood fats with this medication, and very rarely it may cause a tear in the stomach or intestines. So it has some downsides, but again, has been shown to be of benefit in terms of reducing the amount of prednisone and reducing the prednisone side effects that come with the treatment of giant cell arteritis. We still have a lot to think about, though, and this may come up in discussion later, but there are a number of things that we're not yet knowledgeable about, and those would include how long to treat with this medicine, and how to use it, and how to taper it, and the long-term impact of this medicine on patients and on the disease. So we still have things to think about and things to contemplate on. Takayasu arteritis is treated very similarly, and maybe we can leave this discussion for after the break, but we also use similar immune suppressants and biologics. In Takayasu, the TNF inhibitors, adalimumab or Humira, and infliximab or Remicade are often used to treat that disease, but there's now also some initial interest and promising results with tocilizumab that I just went over for giant cell arteritis. We need to keep in mind that vasculitis goes through phases. As I mentioned, at diagnosis, the disease is active, but then it can go through relapses or flares. And with those flares, the downside comes to then causing more damage to blood vessels or to internal organs. Fortunately, in GCA, again, at onset, we're worried about vision loss. Once individuals are started on treatment, that is very unlikely to occur, estimated to be at less than 5%. But there's another complication that we need to be aware of and look for in GCA, and that's the development of an aortic aneurysm. An aneurysm is an enlargement or growth of the aorta, and this can happen because the vasculitis and its damage from inflammation can cause weakening of the wall of the blood vessel, which then over time starts to expand and eventually may form an aneurysm. And an aneurysm can be prone to tearing or rupture, which is of course a medical emergency. So we want to try to look for this complication, which can happen in up to about a third of individuals with GCA. We want to look for this and pick it up before it enlarges to the point that it may tear. So what can be done to reduce damage? Of course, as you are very well aware, we want to diagnose these conditions early. We want to treat as soon as we are confident of the diagnosis. We want to keep close watch on things, follow up closely, try to avoid relapses or at least catch them early, and reducing not just damage related to the disease, but we also want to reduce damage related to our medicines, because our medicines have substantial risk of side effects, especially with the use of prednisone, which we want to be very careful with its use to make sure that we're optimizing optimizing the dosage to the individual patient. So I think we're at time. I'll stop there. Happy to take questions if we have a few minutes.
Could you repeat what you said about the better shingles virus? Because I've been reluctant to get that because I thought it was a risk. I have GPA. So you gave us the name of the better one. Could you repeat that?
Yep, there is a newer shingles vaccine called Shingrix, and it's not a live vaccine, so it can be given and can be used in individuals who are on immune suppressants.
Okay, did you have a question?
Great question.
What are the chances that you can have more than one type of vasculitis at a time?
Not high, fortunately, but that certainly can happen. And as you may be aware, we create these classification systems and we give diseases names. But what I've learned over the years is that those are boxes and classifications that we've created that work for most people, but there's a lot of overlap in autoimmune diseases, and individuals may have more than one autoimmune disease and may have more than one form of vasculitis, or I would say perhaps more than one. Again, I mentioned, we try to sort out large vessel, small vessel, etc. But there are patients who have overlap of blood vessels that are being affected, maybe small and large, or any sort of that combination. So that's a good point.
Doctor, you mentioned that with GCA, it affects mainly in the areas in the head and the arms. How frequently can it affect the legs, the lower legs?
Yeah, excellent question. Not frequently, but it certainly happens. and is a very difficult, for the sake of time, I did not include information about that. It's probably less than 10%. Vasculitis in the legs can be difficult to pick up because 99.99% of the population who come in with leg claudication, so symptoms in the legs when they're walking, 99.99% of the population is going to have cholesterol buildup in the leg arteries. So it often goes undiagnosed or maybe misdiagnosed as being cholesterol buildup until we do the appropriate scans and blood work and so forth. But yes, that's a great point. The legs can be affected in giant cell arteritis and even in Takayasu arteritis, and it can be difficult to tease out cholesterol buildup in the arteries from vasculitis. Great point.
2 questions. Do you ever diagnose patients under the age of 50 with GCA? And we talked only about arteries, but do you ever find evidence of damage to the veins with large vessel vasculitis?
Yeah, great questions. Again, we have these what we call classification criteria, and we always try to tease out. So large vessel vasculitis, whether it's GCA or Takayasu, have a lot of similarities, and we still don't understand where they overlap and where they're different. And so there is some debate in terms of, somebody who's 45, is that Takayasu arteritis? Is it giant cell arteritis? That's a matter of ongoing debate. With regards to the other question, was a great question, remind me.
Venous.
Yes, so generally we don't see direct involvement of the veins in GCA and Takayasu, but we do know that these individuals with large vessel vasculitis and even other forms of vasculitis have a higher risk of deep vein thrombosis. So there may be some inflammation in the veins that we're not appreciating and may lead to a higher risk of blood clots. Yeah, great question.
I was just going to ask that. Do you find there's a higher risk of blood clots so that people with these diseases more often need to be on blood thinners, et cetera? And is that common?
We generally don't use blood thinners in folks who have large vessel vasculitis unless there is a complicating factor like a vein blood clot, a deep vein thrombosis, or pulmonary embolism. Aspirin is often recommended. There's some controversy in the literature about how much that helps, but aspirin may help prevent some of the cardiac or cardiovascular complications in people with giant cell arteritis. But again, blood thinners are generally used only in the context if there's a blood clot, DVT-PE, which patients with GCA may be at higher risk for.